Welcome to your Week 8 lecture. You should have read these 4 chapters by now. Let's get started. This week we'll look at what can go wrong with the digestive system and all of its parts. The digestive system goes from mouth to the anus. As you will see, there are lots of parts to our digestive system which allows for many things to go wrong. The digestive system starts with the mouth and tongue and continues down to the pharynx and epiglottis. There it goes down from the trachea to the stomach. Common disorders seen in this area are dysphagia, odynophagia, or difficulty swallowing or painful swallowing. This can come from GERD or gastroesophageal reflux disease or from strictures of the esophagus. Problems with the UES and LES are also common. These are the upper and lower esophageal sphincters. After the esophagus is the stomach. Its purpose is to digest the food we eat using acids and digestive enzymes. The stomach can get ulcers which can bleed and cause reflux into the esophagus. It can go through the diaphragm and cause a hiatal hernia. Vitamin B12 absorption occurs here as intrinsic factor is made. If the stomach or part of it is removed, then this can affect B12 absorption. Beyond the stomach is the first portion of the small bowel called the duodenum. A barium swallow study can show you how a person swallows a food or drink bolus and travels down the esophagus into the stomach. Is there a stricture or mass blocking the way? Is there inflammation causing a problem with esophageal motility? The patient may need an EGD or upper scope to look for disease. Capsule endoscopy can be done to look for disease as well. Dysphagia is difficulty swallowing or unable to swallow well, while odynophagia is painful swallowing. This can be neuromuscular, like due to a stroke, or due to esophageal strictures from repeated bouts of acid reflux. It may be due to candida infection of the esophagus. Patients with iron deficiency anemia may have Plummer-Vinson syndrome, which is from esophageal webs seen on EGD that can cause periodic bleeding and difficulty swallowing or dysphagia. This can lead to esophageal cancer. Esophagitis is inflammation of the esophagus and can be from GERD or reflux, but can be from infections like Candida albicans. NSAIDs can also cause esophagitis, especially if they get stuck. A Mallory-Wise tear is an opening that occurs in profuse vomiting episodes that causes some bleeding. An EGD can diagnose esophagitis. An EGD or an esophageal gastroduodenoscopy is done under sedation and uses a flexible camera that can enter the mouth through a bite guard, looking much like a bronchoscopy, but instead of going into the lungs, the esophagus is entered. And the scope can go as far as the duodenum. Biopsies can be taken, and the procedure can be modified to become an ERCP or endoscopic retrograde cholangiopancreogram. This is the best test to look for ulcers in the stomach or diagnose H. pylori and take biopsies for celiac sprue. GERD is a gastroesophageal reflux disease from stomach acid moving into the esophagus. This can lead to changes in the esophageal lining near the LES or lower esophageal sphincter. This metaplasia changes the esophageal epithelium tissue to more that of stomach lining. This can lead to dysplasia or cancer cell formation and is called Barrett's esophagus. Adding histamine 2 blockers or proton pump inhibitors can help GERD. Testing includes barium swallow, EGD, or testing the acidity of the esophagus. Treatment can be surgical like a fundus wrap, but this has mixed results as it can affect swallowing ability. An upper GI bleed is most likely due to a stomach ulcer called peptic ulcer disease or PUD. NSAID use is the most common cause of this type of ulcer. Before the invention of H2 blockers and PPIs, stomach ulcers were very serious and difficult to treat, requiring long hospitalizations and surgeries to remove the stomach. Ulcers can bleed acutely, meaning a new fast bleed, or slowly, causing a chronic long-term bleed. Upper GI bleeds cause hematemesis or bloody vomitus. and melena, or dark black tar-like stools, which are from digesting blood. Iron deficiency anemia is a GI bleed until proven otherwise. Sometimes blood in the stools is hard to identify and occult testing must be done. Occult blood testing can show blood in the stools and prove for the need of further investigation of the GI tract. Obvious blood in the stools may not need this testing. It is more for when you are unsure if there is blood present. For example, Pepto-Bismol is a medication many people take for heartburn that can make the stools black. This can be mistaken for melena, and occult blood testing of the stools can show if the digested blood is present. The old adage is 3 stools testing for blood, and if one positive, then do EGD and colonoscopy. But now that scopes are much easier to do, the trigger for these tests are much easier to pull. There's also capsule endoscopy and CT scans that can mimic endoscopy. Esophageal varices is another type of upper GI bleed, but we only see this in patients with cirrhosis. This will be painless, but can be started by a vomiting episode. Diagnosis is primarily by EGD, but it can also be picked up by imaging studies like CT scans or MRIs. Ruptured varices will bleed, and this can be treated by injections of medication or banding, which is rubber bands placed on esophageal varices veins bleeding. Taking regular medications that lower portal blood pressure will prevent this. Esophageal cancer can also cause GI bleeding, but the usual symptom is difficulty swallowing. Diagnosis is by barium swallow study showing an apple core lesion, meaning only a skinny opening in the esophagus is left for the barium to pass through like an eaten apple to the core. Treatment is surgery, if early, with chemotherapy and radiation. Most patients will have to have a feeding tube for a long period of time. Alcohol use and smoking along with GERD are the main causes, and diagnosis includes biopsy by EGD. A Halo Hernia is the stomach entering the thoracic cavity through the diaphragm. The more it enters, the worse the hernia. See this chest x-ray showing a large gastric bubble in the thorax. This is the stomach in the mediastinum of this patient. If it gets too severe, then surgery is the only answer. But most just deal with this and use medications like PPIs and H2 blockers. Patients can have chest pain with this, but will have a slipping feeling, they describe, as the hernia moves. Polywork stenosis is a baby who goes home from the hospital and returns with projectile vomiting for about 6 to 8 weeks old. Usually a boy for some reason, and will not take formula or breast milk without vomiting. This is a surgical issue and needs to be addressed before the baby loses a lot of weight. It can also present much later, up to about 6 months old. First off, gastritis can only be diagnosed by EGD or visual inspection, then biopsies. Now, the difference between acute and chronic is important. Acute is transient due to NSAIDs with heartburn or even some bleeding and abdominal pain. Chronic is long-term, usually due to H. pylori, and causes atrophy of the glandular stomach lining called atrophic gastritis. Treatment of acute is PPI or H2 blockers, while treatment for H. pylori also involves antibiotics, along with acid-reducing medications. Peptic ulcer disease, the leading cause of upper GI bleeding, is the most commonly from NSAID use, which are medications like ibuprofen and aspirin. Diagnosis is by EGD, as we mentioned before. The treatment is by PPI or H2 blockers. H. pylori or Helicobacter pylori is a bacteria that can increase the risk of peptic ulcer disease. Treatment of H. pylori is essential if present. In the past, it was thought that the stomach was aseptic, meaning no bacteria could survive its acidity, but in the 1980s, it was discovered that a bacteria called Helicobacter pylori can live in the stomach. This bacteria can increase the risk of ulcer formation in the stomach. This bacteria destroys chief cells and parietal cells initially, decreasing stomach acid. Then the stomach acid rebounds, causing ulcer formation. Intrinsic factors decreased, and this prevents absorption of B12. Zollinger-Ellison syndrome is caused by a gastrin-secreting tumor, which can lead to ulcer formation in the duodenum. Check the serum gastrin level, then find the tumor if it is elevated. It must be surgically removed to cure this condition. For bariatric surgery, the most common is the sleeve gastrectomy, and this is the one you need to know for the exam. This surgery is not recommended unless the patient has a BMI of 40 or greater. A small portion of the stomach remains, and the patient does have B12 deficiency, likely with lower intrinsic factor. Dumping syndrome is a consequence of most surgeries involving the stomach and or small bowels. It can be a side effect of most of the bariatric surgeries and used to correct obesity. It comes in two phases, early and late, and is treated with dietary management. Celiac disease is the reason for the gluten free fad of the past several years. It is relatively rare and is a true wheat gluten allergy. Patients must avoid gluten in their diets. Diagnosis is from biopsy of the small bowel. There's also a serum celiac panel that can be ordered for screening purposes. The small bowel consists of three sections: the duodenum, jejunum, and ileum. The primary duty of the small bowel is the absorption of nutrients and materials from the food we consume. The liver and pancreas have ducts that enter the duodenum to deposit their products there to aid in digestion. The bile from the liver helps in fat digestion, and enzymes from the pancreas aid in both fat and carbohydrate digestion. We've all had gastroenteritis viruses are the most common and more common than bacteria in any infectious condition. This disease is very common on cruise ships due to close quarters and frequent eating, as they are all transmitted fecal orally. If it is a virus like norovirus or rotavirus, then they are very self-limiting. But if bacterial, then the patient will need antibiotics. Symptoms are nausea, vomiting, and diarrhea. Patients can become very dehydrated. GI bacterial infections can have many complications. We hear about outbreaks of these bugs every day in the news with contaminated food. Hemolytic uremic syndrome can come about from Shigella or E. coli infections, particularly the E. coli 0157H7. To remember this one, think of the H meaning hamburger, as most of the time this comes from undercooked ground beef at cookouts in young kids. Campylobacter jejuni can cause Guillain-Barré syndrome, which is a loss of neural function in distal appendages that can lead to complete paralysis in some cases. We will visit these bacteria again in the GI chapters. Remember again, though, most infections are viruses, and the viral GI infections are far more common. The GI tract has normal flora, or bacteria that we need to help us digest food and protect us from pathogens that can harm us by making a protective layer or coating along the walls. If this gets disrupted by antibiotic use, then we can fall prey to certain pathogens like Clostridium difficile. Clostridium difficile, or C. diff for short, is a terrible watery diarrhea that forms from recent antibiotic use. Using an antibiotic for another infection will kill normal bacterial gut flora and allow this spore to take hold, resulting in a profuse and terrible diarrhea. Short bowel syndrome occurs with a loss of small bowel at or below 200 centimeters in length. This usually comes from a surgery like that of a Meckel's diverticulum or from Crohn's disease, where areas of small bowel dies and has to be removed. There are three phases: acute, which is during the first 3 months and consists of malnutrition and fluid loss; adaptation, which is around 12 to 18 months, where the microvilli begin to lengthen; and maintenance after 18 months, where the patient adheres to their diet. Small bowel obstruction can come from post-surgical adhesions or from tumors or inflammation. This will present with nausea, vomiting, abdominal pain, and distension. This is more common in the elderly than any other population. The exam will show a distended abdomen and hyperactive bowel sounds as the small bowel continues to work against the obstruction. It is diagnosed by abdominal x-ray. Treatment is with nasogastric tube dissection and keep the patient NPO or nothing by mouth. Most will pass on their own, and you have to give them time. Some do need surgery and bowel resection. The patients may have to have an ileostomy if the bowel cannot be reconnected to the colon. This is small bowel coming out of the surface of the abdomen and feces passing through a stoma into a collection bag. Peritonitis is inflammation of the peritoneum. Remember the peritoneal serosa of the abdomen, like the meninges of the cranial and spinal cavities or the pleura of the thoracic cavity. It can become inflamed due to infection, and this is usually from leakage from bowel perforations. The classic cause of peritonitis is a ruptured appendix and appendicitis. The patient will have rebound tenderness on examination, which means you press on the abdomen, it hurts, but if you let go, it hurts much more, as this makes the peritoneum move. The patient will also have trouble jumping up and down or coming down on their soles of their feet in a heel click maneuver. A paracentesis may be necessary for diagnosis, and this can show white blood cells and bacteria. Abdominal x-ray may show perforation with free air into the diaphragm. CT scans can also demonstrate this inflammation. Surgery and antibiotics are usually necessary for treatment. Now to the largest intestine. It is not nearly as long as the small intestine and is made up of the cecum or blind pouch, which has the appendix, the ascending colon, transverse colon, and descending colon, sigmoid colon and rectum, and finally the anus. The large intestine contains haustrations, and this aids in the movement of fecal matter. The main purpose of the large bowel is the absorption of water along with sodium and chloride. Any evaluation of abdominal pain begins with a good history. Where's the pain site? When did it start? Is it continuous, comes and goes? What are the characteristics? How do you describe this pain? Sharp, aching, stabbing? Does the pain radiate anywhere? Any other symptoms associated with the pain like bloody diarrhea or nausea and vomiting? Are there particular times when the pain is worse or better? Does anything else make the pain worse or better? How do you rank this pain on a pain scale from 1 to 10, where 1 is no pain and 10 is the worst pain you've ever had? Next comes the examination. First, inspect the abdomen. Is there bruising, rashes? Listen to the bowel sounds next, as palpation can affect them. Are the bowel sounds active, silent? Next, percussion to see if there's fluid or maybe a mass you can hear. After percussion, then palpation is next. Palpate each quadrant. Feel the liver, spleen. Press on to make Bernie's point. If warranted, do Murphy's sign to see if there's cholecystitis. Look at the patient's face for any signs of pain as you palpate. Where the pain is coming from can help narrow down the cause of the pain. The 4 basic quadrants can help us figure out the cause of the abdominal pain and localize it better. Right upper quadrant could be liver, gallbladder problems. Left upper quadrant could be pancreatitis, spleen issues. Right lower quadrant, appendicitis until proven otherwise, but could also be ovarian cysts or urethral stones and even an ectopic pregnancy. Left lower quadrant could be diverticulitis or any of the other right lower quadrant problems except appendicitis. Any of these could be inflammatory bowel disease like Crohn's, which can go anywhere in the GI tract. Further evaluation with imaging like X-ray, ultrasound, and CT scan may be done along with colonoscopy or sigmoidoscopy. Labs are important clues, as well as elevated amylase and lipase show us pancreatitis is present. Opiates are often withheld until a diagnosis is made, as they can mask symptoms. A colonoscopy is like an EGD, just at the other end. It involves a very good preparation about 48 to 72 hours before, or you'll not be able to see the colon walls. A colonoscopy is a visualization from the anus to the cecum. If possible, a sigmoidoscopy is visualization of the anus to the sigmoid colon. We use colonoscopy to look for diseases and conditions for the entire colon. We use sigmoidoscopy when we only need a limited view of the first portion of the colon past the anus. In a colonoscopy, we can find colon polyps, and removing these growths will reduce the occurrence of colon cancer. This is the reason for the importance of getting colonoscopies after age 50, but if you have a family history of colon cancer, you should get them much sooner. Crohn's disease is one of the 2 inflammatory bowel diseases, which are autoimmune diseases of the GI tract. Crohn's can be anywhere from the mouth to the anus. It presents as abdominal pain and can have GI bleeding. It can be distinguished from UC or ulcerative colitis by colonoscopy findings and biopsy and histology. Crohn's has skip lesions, meaning there can be only one here or there, and then the colon or small bowel is okay. Then there's another one. It will also have cobblestone appearance, as this simulation shows. Much like old Streets of London in a Sherlock Holmes movie, the stones are pressed together to make a street for horse carriages, and And here the tissue looks as if there were cobblestones sticking up from the surface due to the inflammation present. Crohn's has several extra GI manifestations as well. Again, Crohn's disease presents as abdominal pain. It must be distinguished from UC by colonoscopy and tissue biopsy. Crohn's is relatively superficial on histology compared with UC. It is harder to treat since it is continuous and can appear anywhere in the GI tract. It can lead to large or small bowel obstruction because of inflammation. Patients must take immunosuppressants to control symptoms, and this leaves them open to a whole host of opportunistic infections. Is it just me, or does this lady seem to get sick a lot? Ulcerative colitis is the other inflammatory bowel disease. It is continuous with the rectum and always involves the rectum if present. It does not skip around like Crohn's. It can have pseudopolyp formation, unlike Crohn's disease. It also starts with abdominal pain and GI bleeding. Colonoscopy must be done to distinguish this from Crohn's, along with biopsies. For the exam, I made you a table to help you compare Crohn's disease with UC again. Crohn's involves the entire GI tract from mouth to anus, while UC is only rectum and up to the colon only and never involves beyond the ileum. Inflammation is transmural in Crohn's and is superficial mucosal in UC. Histology in Crohn's has skip lesions, while UC is continuous and always involves the rectum. Both have similar extraintestinal manifestations. Endoscopy or with colonoscopy, one can find cobblestoning, as we saw in the simulation imaging of Crohn's, and pseudopolyps can be seen with UC. Both can cause colon cancer, but UC has a much higher risk. This is a CT scan of a large bowel obstruction. It is like a small bowel obstruction, just of the large bowel. Constipation is a key factor for these, but they can also be due to masses or inflammation as well as adhesions from repeated surgical procedures. Patients present with abdominal pain, distension, nausea and vomiting, and lack of bowel movements, although some can have diarrhea first. Just like a small bowel obstruction, we place an NG tube to suction to decompress the bowel. But also we can do enemas here since the obstruction is large bowel to aid in the decompression. Watch for perforations, as these can be serious complications. Colon resection may be needed, and the patient could end up with a colostomy, which is a colon coming out of the abdomen surface in a stoma, and a bag is placed to catch feces. Appendicitis is inflammation of the appendix. This is usually a bacterial infection. The appendix has no known established importance, but may be used for the immune system or as storehouse for normal bacteria. If this tissue is infected and inflamed, it causes pain. This pain can be further elicited by making the area it exists smaller, and this is what you are doing with the obturator and psoas signs. As it inflames, it will cause further symptoms or peritonitis, and thus you will need to have the patient, thus you will find that the patient has rebound tenderness at McBurney's point, which is a specific area of the right lower quadrant of the abdomen. They will also have trouble jumping or doing a heel click maneuver where they stand on their toes and come down quickly on the heels to cause a jerking of the or jarring of the peritoneum. If it causes pain, then peritonitis is likely present. The exam of appendicitis will show signs of peritonitis early as the appendix gets bigger. Many times it will rupture and cause sepsis and peritonitis. If the patient is thin, then you may be able to see the appendix on ultrasound. But if not, the standard imaging study is a CT scan of the abdomen, and this is the most accurate. A CBC may show elevated white blood cell count with a left shift, as we have discussed in previous lectures. Treatment is IV antibiotics and surgery with pain control. IV antibiotics should be given before surgery and 48 hours after. Irritable bowel syndrome is much like interstitial cystitis and occurs mostly in younger women. Just like IC, IBS is a disease of exclusion of other things must be ruled out before making this diagnosis. The patient will either be diarrhea or constipation predominant, or could have a mix of both. They'll have frequent abdominal cramps and need to defecate several times a day, even if they are not productive in doing so. This again has been linked to anxiety and depression, much like IC. Treatment is laxatives if constipation predominant, although this may cause more problems like laxative addiction, and increase in fiber intake if either diarrhea or constipation predominant. Anti-diarrhea medications may be needed for the diarrhea predominant form. Diverticular disease is the presence of diverticula or pockets in the colon wall. It is thought that they form due to bowel wall weakness. They're very genetically inherited. It is also interesting to note that persons in the Western Hemisphere tend to have diverticula on the left, and persons in the Eastern Hemisphere tend to have diverticula on the right side. When these pockets fill with bacteria and fecal material, they can become infected, resulting in diverticulitis. If diverticulitis happens enough times, then fistula formation may occur, like communications between the colon and bladder. The first occurrence of this disease is treated with antibiotics and careful follow-up, but any occurrences after this need surgical consultation due to the possibility of fistula formation. Increasing fiber in the diet can help this disease. It used to be told that eating too many seeds may exacerbate this disease, but this was proven wrong. Volvulus is the twisting of the large bowel. The most common site is the sigmoid colon. It can happen to the young or old. Treatment is usually surgical with Hartmann's procedure, which involves laparoscopic surgery and unwinding or untwisting of the bowel. You can also unwind this with a sigmoidoscopy or just wait with IV steroids and antibiotics to see if it resolves on its own. Hemorrhoids get most of us here. There are two types, internal and external. Internal hemorrhoids only bleed but do not hurt as they lack innervation and are above the pectinate line in the rectum. External hemorrhoids hurt and bleed as they have innervation and are below the pectinate line of the rectum. Hemorrhoids are like varices as they are enlarged veins. They form from irritation or increased venous pressure. Straining, lifting, pulling, pushing can cause them. To see external hemorrhoids, one only has to examine the anus or use an anoscope, but to see internal hemorrhoids, you will need to do sigmoidoscopy. You do not need a full colonoscopy for hemorrhoids. Treatment is banding like varices or sclerotherapy. The liver is a vital organ that helps us eliminate waste and toxins from the body. It helps immobilize glucose when we are lacking it. Damage to the liver can hinder these functions, but the liver is a truly resilient organ as it can regenerate unlike all other organs. Common injuries to the liver include alcohol, hepatitis B, C, as well as fatty liver disease. It takes up most of the right upper quadrant of the abdomen, and if acutely injured, it will get larger, then it will shrink with chronic disease. The liver has many functions that are vital for our body's survival. The most important is the formation of bilirubin, as this waste product will build up in our body if not dealt with. Here are the steps of bilirubin formation. You will not be asked about this on the exam, but be familiar with them. The most important point is to know that if the common bile duct is blocked by a stone or tumor, then the patient will have jaundice. You may have the terms conjugated, or may have heard the terms conjugated and unconjugated bilirubin. Unconjugated bilirubin is indirect bilirubin, while conjugated bilirubin is direct bilirubin. Remember from last week, we learned about the liver can make glycogen for us from excess glucose to store when we need it. We need glucose released. This is essential for us in a starvation state where we cannot eat right away. Toxic substances like alcohol, acetaminophen, which is Tylenol, and other medications we take are broken down by the liver to keep them from harming our other cells. In fact, you cannot take alcohol and acetaminophen or Tylenol concurrently, as they use the same system in the liver for detoxifying and thus will compete and stress the liver, causing damage. It is important for patients with liver disease or those who consume alcohol to stay away from acetaminophen products. The liver also stores some vitamins, produces insulin like growth factor 1, and makes thrombopoietin for platelet synthesis stimulation. This CT scan shows a common bile duct stone. If a stone blocks the common bile duct, then this will cause jaundice. The stone usually travels from the gallbladder down the cystic duct and can get stuck in the common bile duct or lodge just at the opening at the sphincter of Oddi. Jaundice or icterus is the buildup of bilirubin in the tissues, particularly the skin and the sclera of the eyes. It occurs when the common bile duct is blocked or the liver is inflamed due to a virus like hepatitis or toxicity. It can also come about from too much blood to process at one time from genetic diseases like Gilbert's syndrome, where the patients metabolize bilirubin much slower than a normal patient. And when they get stressed, they become jaundiced. Patients with jaundice may itch excessively as bilirubin can irritate the skin. Liver inflammation can come about from many sources, including toxicity from medications or substances like alcohol, and cause pain. Hepatitis viruses can also cause liver inflammation and lead to jaundice. Toxicity of certain substances like acetaminophen and alcohol together can lead to liver failure. Liver inflammation usually is accompanied by right upper quadrant pain. Patients may have jaundice, pruritus, dark urine, and a host of other symptoms. Understanding what's going on with the liver, like all other aspects of the digestive system, involves a good history and physical examination. When did the symptoms start? Is the patient jaundiced? Do they have pruritus? Signs of spider angiomas, caput medusa? Do they have ascites or steatorrhea? We have determined if this patient we have determined if this is just acute inflammation or is the liver failure or chronic cirrhosis going on. Labs and imaging studies are next to see what's going on with the liver. ALT and AST, as well as alkaline phosphatase, can show us how the liver is functioning. If really elevated, this means the liver is in acute inflammation of some kind. Ordering bilirubin studies, such as direct and indirect, can also help us see how the liver is handling bilirubin elimination. Certain patterns in this can show us what may be going on. Albumin being low tells us the liver injury has been going on much longer than in the acute phase, and PT or prothrombin being affected also tells us the liver is not making proteins as it should, and this may be more serious than we think, and the patient could be in liver failure or cirrhosis. Imaging studies can also help us to see if the liver has a mass or obstruction. Liver biopsy is the gold standard to determine the cause of the liver injury and inflammation. Cirrhosis is liver failure and end-stage liver disease. This can be caused by chronic hepatitis like hepatitis C or B, or with D, alcoholism, and non-alcoholic fatty liver disease. Portal hypertension will develop, causing enlarged veins. Decreased albumin along with portal hypertension will cause ascites. Esophageal varices will form from the increased portal pressure. Easy bruising and bleeding may ensue due to decreases in synthesis of clotting factors and the decreased platelet count from the lack of thrombopoietin. Jaundice will present as the liver cannot process bilirubin effectively. Cirrhosis can lead to elevated ammonia levels in the blood, which can lead to hepatic encephalopathy, causing confusion and sleepiness. Patients with cirrhosis frequently are anemic and thrombocytopenic. They are edematous with third spacing of fluids in the abdomen called ascites and in the lower limbs. This backup creates preload on the right side of the heart and can lead to right side heart failure. The kidneys may not be able to deal with the fluid loss where the fluid goes into the abdomen and tissues, and this may lead to renal failure. Hepatic failure due to renal failure because of the hepatic failure, and this is called hepatorenal syndrome. Hepatic encephalopathy is from the accumulation of ammonia in the blood, creating confusion in the patient, and many times they become sleepy and may not wake up easily. This can be a serious problem for caretakers of patients with end-stage liver disease. Asterixis is a sign of hepatic encephalopathy. If the patient's ammonia level is elevated, then having the patient show you the palms of their hands and hold them up will cause the hands to flap uncontrollably. This is known as the liver flap or the liver wave and is an important physical exam finding to know. Here is a table to help us compare the different types of hepatitis virus. A is self-limited. You see it on the news all the time. It is a fecal oral transmitted, and you can get it from eating unwashed vegetables. It will not lead to cirrhosis and goes away on its own. B is from blood or sexual contact and can lead to cirrhosis. There is a vaccine to prevent it, though. It is the only DNA virus of the group, with the rest being RNA viruses. It stays with you for life once you contract it, and there is no cure. C is also chronic hepatitis virus that is blood and sexually transmitted and can cause cirrhosis. It does not have a vaccine, but there is a regimen of antiviral medications that can cure it. A genotype must be done to determine what strain of C you have to come up with, so you can come up with the best regimen of medications to eliminate it from your body. D is a covirus with B. If you have chronic hepatitis B and get D, you're guaranteed to progress to cirrhosis. This is why it's so important to get the hepatitis B vaccine. It is also blood and sexually transmitted. E is another fecal oral virus, but we don't see it here much. It is found in third world countries that have poor water supplies and usually follows diseases like cholera. It is self-limited as well and usually will go away. Non-alcoholic fatty liver disease, or NAFLD, the most common form of liver disease in the country. This occurs in persons with metabolic syndrome, obesity, particularly type 2 diabetes. It can also manifest in patients with hyperlipidemia like familial hyperlipidemia, which we discussed in previous lectures. The depositing of fat on the liver will cause fibrosis, then cirrhosis over time. Liver imaging may be the only sign of liver disease in the earlier stages. Risk factors like a high-fat diet, high BMI, and obesity will increase the chances of developing NAFLD, also known as NASH or non-alcoholic steatohepatitis. Liver biopsy is key to diagnosis, as with most liver diseases. Weight reduction and low-fat diets will help to stop the progression of this disease. Alcoholic liver disease used to be the number one cause of liver disease, but NAFLD has overtaken it recently. Alcohol consumption in excess over a period of time will begin to damage the liver and cause it to look fatty on imaging studies. Then fibrosis will set in and cirrhosis eventually. Acetaminophen along with alcohol consumption will accelerate this effect. Alcohol intake needs to be reduced to reduce the chances of this from happening. Alcohol is a well-known liver toxin, and many drink too much and will not provide accurate alcohol use histories. Pain after heavy binge drinking can occur in the right upper quadrant of the abdomen, and liver inflammation from alcohol damage can elevate liver transaminases and cause temporary jaundice, fever, and hepatomegaly. The more alcohol taken in by the patient in a shorter time span can increase the chances of alcoholic cirrhosis than liver failure. Long-term alcohol use with lesser amounts than the acutely toxic can still lead to cirrhosis if enough is consumed for a sustained period of time. This will subject the liver to repeated attacks of this toxic element until inflammation, then fibrosis sets in. The patient may see many signs of cirrhosis, as we have already discussed, as the disease progresses. In the earlier stages, it can be reversed if alcohol cessation is done. Biliary cirrhosis is usually caused by an autoimmune reaction that causes inflammation of the bile ducts of the liver. This can progress to advanced liver disease if not treated. The hallmark lab is anti-mitochondrial antibodies for diagnosing, along with IgM elevations. These patients may need a liver transplant. Wilson disease is an autoimmune recessive disease causing copper deposition all over the body. Most patients with this disease presents later in life with liver issues like jaundice and elevated liver enzymes. It is found after they're working up the liver for liver problems. Its defined characteristics include a Kaiser-Fleischer ring of the eye and an elevated serum ceruloplasmin level. Crigler-Najjar syndrome is mostly benign deficiency of gluconeotransferase in babies, and it can be treated with light therapy. More serious occurrences of disease can lead to ammonia buildup and hepatic encephalopathy. Also, liver failure can happen in rare cases requiring liver transplantation. Gilbert's disease is completely benign, and these patients only metabolize bilirubin slower than their average person, causing jaundice when they get stressed or anxious. You only need to calm the patient down for symptoms to improve. Hemochromatosis is iron deposition and can lead to liver disease and cirrhosis. These patients must donate blood to remove excess iron stores and reduce iron deposition. Diagnosis is made by doing serum iron and ferritin levels. Patients can have dark skin, fatigue, and joint pain as well. Liver transplants can be from cadavers or deceased individuals, or it can be from living donors. Each patient ends up with half a liver, and in the span of 1 year, both will have a full liver. This is because the liver is resilient and divides rapidly. The gallbladder is used as a reservoir for bile and the aid of digesting fats. The pancreas is both an endocrine and digestive system organ. The pancreas is also both an exocrine gland and an endocrine gland. The close approximation of these two organs can affect each other. For example, a gallstone can cause pancreatitis if it blocks the pancreatic duct. The gallbladder is not an essential organ and can cause many issues. It can develop stones and cause biliary obstruction. It can be acutely inflamed. It can cause sepsis or can be chronically dysfunctional and result in pain when eating fatty food. As you recall, a common bile duct stone can cause jaundice, as we discussed with the liver. Gallstones are mostly made of cholesterol and can cause pain and obstruction. Many have gallstones and never know it until one goes down the cystic duct and gets obstructed for a time, causing pain. Many patients elect to get their gallbladders removed only because they have stones present, which increase the risk of biliary colic, pancreatitis, and cholecystitis in the future. Cholecystitis has a similar appearance as biliary colic, and both can have positive Murphy sign. Pain in the right upper quadrant of the abdomen can radiate to the back of the shoulder, the right side, along with nausea and vomiting. Biliary colic usually goes away as the stone passes, but cholecystitis does not. If the stone is stuck, then the biliary colic pain can continue and lead to cholecystitis. If the acute cholecystitis goes on, it'll worsen in pain and may cause sepsis. Chronic cholecystitis only occurs after a fatty meal and will go away after a while as well. It is not dangerous as acute cholecystitis. Cholecystitis is mostly seen in Caucasian women, obese patients, those who are fertile or on hormone therapy like estrogen, and women and with a family history of cholecystitis, and women in their 40s and 50s. These are the 5 F's of cholecystitis. A Murphy sign is where you press on the gallbladder while the patient takes a deep breath, and as they exhale, you press harder. And if the patient's exhalation is interrupted by pain, then this is a positive sign. Treatment for cholecystitis is a cholecystectomy, or removal of the inflamed gallbladder. This is usually done by laparoscopic surgery. The patient will go home the same day in most cases. Ultrasound is the best at diagnosing cholecystitis, but CT scan can also diagnose this condition. Labs with elevated white blood cell count, ESR, and CRP are also helpful but not diagnostic. An ERCP is like an EGD as we discussed before, but now you can go to the duodenum to assess the bile duct and pancreatic duct to get out stones. This procedure is mainly done to remove stones and place stents for others to pass. Sometimes it is used for biopsy of the pancreas. It can cause acute pancreatitis and therefore is contraindicated in acute pancreatitis unless it is caused by a gallstone that needs to be removed from the pancreatic duct. Acute pancreatitis can be deadly. It is mostly caused from alcohol, but can also come from gallstones, as we discussed before. Elevated triglycerides due to fatty liver disease like NAFLD can also cause acute pancreatitis, and acute pancreatitis can in turn cause more elevated triglycerides. The patient will have epigastric pain, more left than cholecystitis, and will not be a Murphy sign. Nausea and vomiting are almost always apparent, and the patient may also be jaundiced. Supportive care is the only treatment by giving IV fluids and starting nutrition that rests the pancreas, like and floating an NG tube past the pancreas into the duodenum and tube feeding until the pancreatitis resolves. Feeding a patient by mouth too early with pancreatitis can cause relapse, but withholding nutrition will prolong pancreatitis as well. The hallmark of pancreatitis is elevated amylase and lipase in the presence of epigastric abdominal pain. Then get a CT scan to confirm your diagnosis. Some patients with advanced pancreatitis, like necrotizing or hemorrhagic pancreatitis, may have Gray Turner or Colon signs. They are very rare and usually in patients who are very ill. Gray Turner sign is bruising or ecchymosis of the lateral sides of the abdomen, while Colon sign is ecchymosis or around or just inferior to the navel. Acute pancreatitis is diagnosed by CT scan best. Here we have the patient with acute pancreatitis. As you can see it well in the green box CT images showing pancreatic stranding or a fuzzy and stretched out appearance to the pancreas. The severity of acute pancreatitis is measured by Ranson criteria, as seen here. The higher the score, the worse the mortality and outcome. Each item gets 1 point on a 0 to 11-point scale. First points are found at admission. For example, if it is alcoholic acute pancreatitis and the person is older and at age above 55, or their white blood cells are above 16,000, LDH greater than 350, and AST greater than 250, then they'll get a 4 points already at the start. In 48 hours, if they have hematocrit drop by 10% or more, and BUN rises greater than 5, and calcium drops less than 8, and a fluid loss of greater than 6 liters is found, then there are 4 more points to add to this total for a total of 8 out of 11. So this patient with 8 points would have an estimated mortality of about 40%, which is very high. Chronic pancreatitis is much different than acute. Like cholecystitis, chronicity of this disease greatly reduces the acute danger and mortality. Here we're dealing with a progressive pancreatic dysfunction as the patient experiences pancreatitis over and over again. Usually these patients are alcohol abusers and will have repeated bouts of pancreatitis over a long period of time. Eventually they'll have chronic changes in the pancreas that can be seen on imaging studies. They frequently have digestive problems and require pancreatic enzyme supplementation to take with meals. They can develop type 1 diabetes if the pancreas is damaged enough from recurrent disease as the beta cells are damaged. It is imperative to avoid narcotics in these individuals as they easily become addicted to them. They can have nerve blocks done to nerves that can go to the pancreas in order to reduce pain. Chronic pancreatitis can be confirmed by biopsy during an ERCP or in images seen on CT or MRI scans. Pancreatic cancer is an insidious disease, meaning the patient has no symptoms until late stages. There is no good screening exam for this, like for colon cancer. For example, when it is diagnosed, it is usually too late for effective treatment like surgical removal of the tumor. Risk factors include alcohol, smoking, diabetes, chronic pancreatitis, and nitrites. Some patients present with a painless jaundice and then a pancreatic tumor is found. Sometimes they have a pancreatitis-like pain, but no pancreatitis signs like elevated amylase or lipase, then the tumor is found on CT. Jaundice only appears if the tumor is in the head of the pancreas. Here's a pancreatic cancer cell by electron microscope scan with an extension and shared plasma membrane making a bridge to another pancreatic cancer cell. Biomarker CA19-9 can be elevated in pancreatic cancer. So if a patient comes in with vague abdominal pain with cancerous tumors seen all over the abdomen, and this marker is elevated, then one can deduce that pancreatic cancer is the likely cause. If it is early, before any metastasis, then removal of the pancreatic tumor by Whipple procedure is curative. When it comes to cancer, if you can cut it out, then it can be cured. But if there is metastasis, then cutting out the tumor would be futile, as it has begun to spread and will continue to do so regardless of the original tumor. Most patients with this cancer die, and there is no effective treatment once metastatic spread has begun. At this point, treatment is solely used to prolong life and not cure the disease. This is the end of the Week 8 lecture. I hope you're a lot smarter now.